you check the podium mic and see if you can get it on? It's my great pleasure to introduce Dr. Rebecca Dresser, Professor Rebecca Dresser. Professor Dresser is the Daniel Noyes Kirby Professor of Law and Professor of Ethics in Medicine at Washington University in St. Louis. Since 1983, she's taught medical and law students about legal and ethical issues in end-of-life care, biomedical research, genetics, assisted reproduction, and related topics. Before coming to Washington University, she taught at Baylor College of Medicine and Case Western Reserve University. And in 2003, she was a visiting research scholar at the University of Tokyo, where she taught a short course in law and bioethics. She received her law degree from Harvard Law School. I won't go through the very long curriculum vitae that she has. Suffice it to say that she's the author of many publications and books, and I'd like to recommend to you the book that we all just read in preparation for her visit called Malignant, Medical Ethicists Confront Cancer. And some of you are shaking your heads and probably already have encountered this fascinating book of stories of ethicists, bioethicists who've had cancer themselves or cancer or became cancer caretakers for members of their family. From 2002 to 2009, she was a member of the President's Council on Bioethics, and in 2011, she was appointed to the National Institutes of Health Recombinant DNA Advisory Committee, and it's our great pleasure to welcome you today, so thank you for coming.
Everybody hear me? It's wonderful to be here. I've told a few people I grew up in Indianapolis, and one of my old college roommates just came up to say hello. I haven't seen her in too long. It's amazing. So that was really fun. So people who teach bioethics and write about it often look at topics related to cancer. Things like medical decision-making, patient-physician relationship. Notice I said patient first. Clinical trials, access to health care. So I'm going to talk today about work related to the project that led to the book that Paul just mentioned. This involved 7 people from the field of bioethics. 5 of us had had cancer ourselves, and 3 had been caregivers for spouses. There was one person who unfortunately had had both experiences. So we all teach and write about bioethics, but we have different training in other areas such as law, medicine, anthropology, sociology, literature. So in some ways it was, even though it was a bioethics group, it was also diverse in a disciplinary way. And so in the project, we considered whether our personal experiences were consistent with the bioethics material that we had read, taught, and even written ourselves. Were we really right in what we had understood before? We really looked at clinical practice and ethical analysis in light of the insight that we gained through experience. And we wanted to capture elements of cancer ethics that perhaps hadn't been recognized before. We hope to reach some different audiences, people like you, and then also people in the field of bioethics, and then perhaps some general people from the general public. So we really tried to write it so it wouldn't be too academic. Our methodology was case-based analysis, but so we were looking at ethics from the bottom up, but the cases were our cases. We met a couple of times, and before our meetings, we wrote short essays about experiences we had had that raised ethical issues to us. So we talked about them and a lot of other things, and taped and transcribed the meeting. So this transcript is a very rich resource for the project. So we looked at our experiences kind of chronologically in 3 phases. The first one was kind of up to the diagnosis. So some of us had symptoms, and we didn't know what they were, and how long did we wait to get them looked at, and then how many different doctors did we have to see before we were diagnosed correctly. And then some of us were diagnosed just on mammogram and prostate cancer screening. So different ways that we came to that. Experiences with misdiagnosis, how doctors told us about our prognosis and treatment options, and dealing with conflicting medical opinions. The second phase we looked at was the treatment phase, so what life was like when we had chemo, radiation, surgery, and so forth, the burdens, what it was like to be in the hospital, how we tried to stay connected to the real world or not. Some of us didn't really want to, many of us did. And then after treatment ends, so what most people call survivorship, but what we prefer to call life in the remission society. Because you're never really cured, you're always in remission. And one of our members, Arthur Frank, had made up that term, and so that's what we use. So things like going back for our follow-up scans, how it felt to go back to work and try to integrate what we'd learned into our work. 2 of our group members lost their spouses, so then they were dealing with, first of all, how aggressively to treat, and then when to say, okay, let's stop and go into hospice, and that part of it. So the topics are, some of them are kind of standard, like clinical trials, volunteering for research, coping with uncertainty, but many of them are maybe things you might not think are ethical topics, but one thing we discovered was there's ethics everywhere, even in mundane things like why do patients have to go to the ER on weekends? That's a terrible thing for cancer patients. So we kind of looked at the whole situation. So we have a chapter on cancer stereotypes, issues for caregivers, kind of being in the middle between the patient and the clinician, the spouse, caregiver, cancer interactions, mostly about people outside the healthcare setting, all the bad things people said to us, things that weren't very helpful, as well as the wonderful things people did. Support groups, advocacy groups, cancer and mortality, and then what it's like to be a, quote, survivor. So that gives you a flavor of it. And so what I'm going to do today is tell you some stories, and after I tell a story, stop for a few minutes and talk with you about thoughts that you might have about the story before I go on. So be prepared if you have any sort of questions or concerns that come up. So one of the stories is by one of my colleagues, John Robertson, whose wife had cancer. In 2005, John and his wife, Carlotta, who were both professors at the University of Texas, had planned a trip to London for a conference and then to celebrate Carlotta's birthday. So the day before they were supposed to leave, Carlotta told John that she hadn't been feeling well. Her stomach was swollen, and she had gone to see a family practitioner she had seen before about minor things. She was somebody who really hadn't been very sick in her life. So the doctor had ordered an ultrasound and had the results, but told her it would be okay to go ahead with the trip and that she could have more tests when they got back. So this news was a shock to John. Carlotta was somebody who rarely complained about aches and pains, although he did know that she had had some episodes in the past few months where she hadn't felt well. He didn't know what to do. He felt he's a lawyer, a law professor, but he had worked a lot in medical ethics, so I thought, well, I'm the one who knows the system, so I should know what to do. But he didn't know what to do. He didn't think they had time to sort of deal with it before they left. She was insisting that they went, and they said in her family, they called her someone with a whim of iron, not a will of iron, a whim. So any whim you couldn't talk her out of, and she wanted to go. So they went ahead and left. And when they got to London, for a few days, they were seeing plays and enjoying themselves, but Carlotta was becoming more and more weak. And they finally decided they should cut the trip short and come home early. They got home, and Carlotta had a CT scan, and so they met with the family practice doctor to talk about the results. He told them he didn't have the full report, and that more tests would be needed to determine what was going on. He advised them to see a specialist and arranged an appointment with Carlotta's gynecologist the next day. Later, John found out that the family practitioner actually did have the full report, and he knew that Carlotta had advanced cancer. The doctor had concealed the ultrasound report results indicating probable cancer, and had told Carlotta to go ahead with the trip. Apparently, he couldn't bear to tell them the bad news. So then they're at the gynecologist the next day, and she directly and forcefully announced that Carlotta's abdomen was, quote, full of cancer. She offered no words of support, just made an appointment with a cancer specialist, and rushed them out of her office, which is the way he saw it. So a few days later, they got to the gynecological oncologist, who said that the cancer appeared quite advanced. She recommended chemotherapy and then surgery. This doctor was straightforward, but more compassionate and humane, even though this was the first time they had met her. She, right there when they were in the office, she called MD Anderson for a second opinion, and they were very happy with her, even though, the news was bad. So then they knew it was serious, but, they didn't know how serious. Eventually, the diagnosis was late-stage ovarian cancer, so that's a bad diagnosis. So once treatment was underway, they got some more signals that the condition was grave and serious. Nobody still had sat down with them to go over it. But when Carlotta was having her first chemotherapy, the oncologist came into the chemo suite, which is unusual. I know none of us in the group had that happen where our regular doctors would come in. They were kind of separate settings. And she sat down with them for a few minutes just to talk. And she brought up death. She said, although many people think a sudden death is a good death, she thought that having time to say goodbye and settle accounts was in many ways better. So the message John wrote was clear. She was preparing them for bad news and low expectations. They got another signal from the doctor that night. Carlotta developed a high fever in reaction to the chemo. So the oncologist told them to go to the emergency room right away. There, in the course of examining Carlotta, an ER doctor said to her, "You have terminal cancer." This was a shock to them because even though they were getting the picture that this was serious, they really hadn't thought about it in that way. And the brutality of that statement instilled in them a loathing of the ER, and they never went there again. So I've told you about 4 doctors faced with bad news for a patient, and different responses. So any thoughts about that? Reactions? Yes. Yeah, so I'm supposed to repeat the question for the broadcast audience. The question is, do John and Carlotta regret that the family practice doctor did not tell them what was suspected at the time and let them go on the trip? Well, I'll tell you a little bit more about that later, but yes, John was very angry about it. He doesn't say how Carlotta felt, but he was very angry that he didn't say this looks like it's serious. We ought to get some, more testing. Had you see a specialist right then? Yeah. So. Any other thoughts? Yes, in the back.
Whether she wanted to have the treatment or not. Did the doctors give the patient a choice of whether she wanted to get the chemo treatment or forgo that treatment? Or did they just assume that that's what she wanted to do?
They gave her a choice. The medical situation was that when ovarian cancer is advanced and it was all over her abdomen, so you can't really take it out with surgery. So the idea was with chemo you would try to shrink the tumors and then they would be able to get more of it out with the surgery, and she went along with that. So they were good on that part of it, yeah. Yes, sir?
Just in regards to the question at hand, I think I'm a physician, and it's not surprising to me at all that this is how this was handled by the physicians that were involved, because while this is probably the most complex thing that we do as physicians, relay bad news and talk to people about sort of life and death sensitive issues, we aren't taught at all how to do that. So I'm an intensivist. I work in ICU, and this is the most complex procedure I do on a daily basis. But whereas I've been taught very explicitly how to put in a central line or to put in a chest tube step by step, I've never been taught how to sort of display empathy and good communication skills in the setting of relaying bad news. So this is, anyone who's dealt with a physician on any realm has had this happen. My wife will tell you that she deals with me every night, and I display very little empathy there. So I'm not surprised.
Yeah, very, very good point. All right, well, let me go on a little.
Professor Dresser.
One more.
Hi, I work with case management now, but I did work with oncology, head and neck cancer. Did you guys address the patient and family's receiving of the information from the doctor? Because I worked specifically with head and neck cancer. He would sit for an hour, and he would go over this so very carefully. And then when he left the room, they didn't hear that they had cancer.
Yes. Yes. People protect themselves from information they don't want to hear. I think that's true. None of us were really like that, but I know I've seen that in other settings. Okay, well, let me tell you a little bit about in the book and in this chapter, people who had especially good stories related to the topic took the lead in authoring, but we bring in experiences of the rest of us too. So obviously, John and Carlotta dealt with some doctors who displayed what we're still, even though we shouldn't have been surprised, we were surprised by how insensitive some doctors were. The gynecologist who had been seeing Carlotta, on a regular basis, who didn't say anything about how sorry she was to have to tell her about this, or to, give any support, just wanted to get her out of there. that was very disappointing. The emergency room doctor who had never seen this woman in her life, and why was it even relevant? Why did he say you have terminal cancer? I don't know. Maybe it did have something to do with her situation, but she was just reacting to chemo and having a fever. Then, of course, the evasive behavior of the family practice doctor. Some of the rest of us had doctors who were pretty good at breaking the bad news, but then didn't sort of tell us about the next step. So, I'm pretty sure it's cancer. I think you have cancer. Nothing about whether it was treatable. So those of us who did have treatable cancer had to spend like a week or something before we had the next meeting wondering, are we terminal? What's out there? That's a terrible time of uncertainty. And, of course, you don't know for sure what the recommended treatment is and what the prognosis are. But to say something about the next step is really important, we thought. And even when it's advanced, like with Carlotta, she lived for 2 more years and was very active. And, there are things to be done, keeping people comfortable, that sort of thing. Sort of what a plan for the future is in, sketch it out, I think is something that can really help patients. One thing that I know is an issue, when you have reason to suspect cancer, but you truly don't know and you need more tests, what should we do? Well, one of Art Frank's doctors was very helpful in this situation. Art asked him, do you think it might be cancer? And the doctor, who was actually a sports medicine doctor, talk about not having training in breaking bad news, this was actually in Canada. And Art had a cancer that people were mystified by, and he was an athlete, so people thought it might be an injury, a sports injury. So anyway, the doctor said, yes, it could be cancer, but if it is, we'll be right there with you. And Art had cancer back in the early, I think the late 80s, but he still remembers how reassuring and comforting that statement was. So I think that's an example of a really helpful thing to do. Many of you have probably heard of this approach called SPITE. It's about breaking bad news. It breaks it down into 6 steps. Setting up the interview in a private area, assessing patients' perceptions of their medical situations, what do you know? Inviting patients to show how much information they want, because not everybody wants a lot. Giving patients some knowledge about their disease, addressing patients' emotions, which can be the most difficult part, they said, and summarizing a strategy for the future, which I was talking about earlier. So I think the emergence of guidelines like these makes it possible for doctors to get better at breaking bad news, even though there are going to be limits to any cookbook approach. Any doctor who followed those guidelines would be better at delivering a cancer diagnosis than were most of the doctors our groups encountered. And we were very privileged patients. Many of us were getting treatment in the places where we taught, and, well insured. And so, if we had that experience, think of, the general public. It's disturbing. There are special challenges. How do you deal with denial and hope? There's been a lot of good material written on that. With a life-threatening disease like Carlotta had, patients and families often hope for a miracle, but also have more achievable hopes, small hopes, like comfort, getting people back to work, active, and doctors can do a lot to make those kind of hopes a reality. Carlotta was able to go back to work. She was a professor, and she worked up until a couple days before she died. So that was really a wonderful thing. Looking back, John can see that that Carlotta's oncologist was trying to focus their attention on smaller hopes, like getting Carlotta back to work, and that by coming into the chemotherapy suite that first day, she was trying to ease them into what the future would look like. And so they were actually very appreciative of her coming in and bringing up death so early, although, it was a shock in a way. The way she did it, they found was very effective. Looking back at the family practitioner, John was angry, still angry. He's also angry that this family practitioner never checked to see what happened, how Carlotta was doing, and this is someone that she had seen for several years. But he can also see that the family practitioner was probably out of his depth. He didn't have a lot of information. It was a complex disease. He wanted the experts to handle it. So, he passed it on. Perhaps there would have been a better way to ease her into it, like, we'll be right there with you if it is serious. But in hindsight, John's become a little bit more forgiving of that conduct, although certainly not ideal. So the point is really that truth-telling is complicated. You ought to tell the truth, but how you do it, when you do it, the way you do it is very challenging. So I'm going to tell another story that I think may illustrate some more complexity to this issue. So this is a story I wrote about, not in the book, but in an article that came out this summer in a journal called, Narrative Inquiry in Bioethics. And it was an issue called Taking Bioethics Personally. So it was all people in bioethics writing about personal experiences that enlightened their professional understanding. So mine is called A Terrifying Truth. So my father died of cancer when he was 39 and I was 12. And this is right here in Indianapolis at St. Vincent's, the old one. So during that time, nobody told me or my younger brothers that he was dying. He went to the hospital in October and died in December. And we only saw him twice during that time. This was the 1960s, and children under 12 were not allowed. They were only allowed in for special exceptions, so we got to go twice, but basically children were unwelcome. Nobody explained to us what was wrong with my father, but we knew it was something bad. You cannot hide these things. My mother was never home. We spent many hours in the care of our relatives. Every so often, one of us would become brave enough and ask when our dad was coming home. And we would get these vague replies that were meant to reassure us, but certainly did not. I will never forget this unsettling time. All the grown-ups around me acted as though, or tried to act as though nothing was wrong. But why was I hearing my mother crying in the middle of the night? And why were we having to eat these yucky casseroles our neighbors were bringing over for dinner? You know how kids are about food. So finally one night, our minister and some relatives came home with my mom and told us our father had died. And of course this was awful and a shock, but also there was part of me that said, okay, now I get it. It was a relief to know what was going on. So this is the way that the first time I learned that people should tell the truth about serious illness. This is the way that I learned that shielding even children from bad news does them no service. My father's cancer was my introduction to medical ethics, and it really began a lifelong fascination with this topic. I didn't realize it until way into my career, and then why I'm so interested in these issues. Anyway, I went to law school, and I was lucky enough to find a job in the field. So once I became a professional, the stuff I did, I always remembered my experience, but most of my knowledge about cancer was professional. But then, 43 years after my father's death, cancer became personal again, and I got my own diagnosis. So when I was 12, I learned how frightening it can be when people don't tell you the truth. As a patient, I learned how frightening it is when they do tell you the truth. Knowing about a life-threatening diagnosis may be better than not knowing, but it is terrible knowledge. With it come impossible treatment choices. For me, the choice between surgery, possibly more effective, but more likely to leave me unable to speak and swallow. On the other hand, chemo and radiation, possibly less effective, but more likely to preserve speech and swallowing. So I had my values, survival, quality of life. Well, I had no idea. How do you balance those? I really needed a lot of help from my doctors. And the tumor board recommendation was really a lifesaver for me. So I found I became much more dependent than I thought I would ever be about that. So knowing the truth made me need a lot of hand-holding. And then, once I made the decision to have chemo and radiation, I evaded the truth. The truth was that the treatment might not be effective. But I didn't want to think about it at the time. I didn't want anyone reminding me of that, as I had to go through the pain, nausea, vomiting, and other side effects without some protection from the truth. I needed that protection from reality. So denial can be selectively absolutely essential. We talked about that in our group. Certainly you can't have it all the time. It's not good, but you need it to get through the day sometimes. Basically, what this taught me was that truth-telling in medicine is necessary, but it is coping with the truth is more difficult than I expected. I can see why my mother didn't tell her young children that their father was dying. I can see that she was, even though she didn't succeed in protecting us, she was trying to protect us from the burdens of truth. She was trying to bear them all herself. So before I had cancer, I didn't realize how much help patients and their families need in coping with the truth. My mother needed someone, and this was back in the 60s, so nobody thought of this, but she really needed someone who could talk to her about it. Well, how are you going to tell your kids? You don't get enough training in breaking bad news, but patients and their families get no training. And one thing in the book we talk about is the burden on us of telling our families, breaking the bad news to others. That was one of the hardest things for us. That kind of support can be very meaningful. I needed doctors and nurses who could help me choose a treatment and then let me put aside the truth while I went, so I could concentrate on getting through the debilitating treatment. So truth-telling is the least worst action when serious illness occurs, but truth-telling is destructive too. It inflicts a new and terrifying reality on patients and the people who love them. So besides telling the patients the truth, doctors and nurses should try to reduce the destructive effects. Sometimes this means talking to patients about how they will convey the truth to their loved ones. Sometimes this means recommending the treatment to a patient overwhelmed by the truth. Sometimes it means downplaying the truth that a burdensome treatment could fail. Now, I don't want to go too far with that because I do think at some point it's very important to talk about when a treatment becomes very burdensome and, has a good chance of not working. I think we do have to bring that up, but delicate. So personal experience taught me how complex and delicate truth-telling in medicine can be. We can talk more about this truth-telling business in a moment. I wanted to get to my third story because I put it in my learning objectives for the lecture, so I want to follow through on that. So this one is about treatment decision making and about a stupid treatment choice I made. So I had radiation for oral cancer, and it definitely affected my speech. You can probably tell. But before I had this radiation, the oncologist and a resident sat down with me and told me about what it would be like. And they gave me a written consent form and showed me PowerPoint slides, which was very, informative. One of the slides had a picture of a man with a feeding tube, because they told me that 50% of the people who got this radiation would need a feeding tube. Immediately, I was saying, well, I am going to be in the top half. No way I'm having a feeding tube. But anyway, the man with the feeding tube was overweight, and so most of the time when I saw the slide, I was thinking, well, why does he need a feeding tube? I wasn't really focused on it. So that's a lesson about the information people take away. Anyway, by the time I was hearing this, I was much thinner than the patient in the slide. I'd already lost weight because the tumor was making eating difficult, and then I'd had chemo, and so whatever I could eat, I had trouble keeping down. But I was determined I was not going to have this feeding tube. For me, in medical ethics, feeding tubes were things that people like Nancy Cruzan and Terry Schiavo had. And I was not going to be one of those patients. I wasn't going to be in that group. I had other reasons for refusing. I already had a port in my body for chemotherapy, and I didn't want another mutilation and bionic woman kind of thing going on. So that was another thing. I still could control what I ate and drank, and also I was at home, and I didn't want to give up the security and control that I had with those things. I'd have to go into the hospital to get the tube, and I knew from my work that people make mistakes, and you could get an infection, and so I didn't want to be exposed. I would probably have a loud television in the room with a roommate, and no way, I didn't want to do that. I also had been a fitness athlete, and I was like, I'm strong, I can handle this. I was also taking pain meds. Maybe that was confusing me, but I think really I'm a stubborn person. And when you have cancer, you don't turn into some saint. You're still you. And so your character traits remain and influence how you behave. And, I was exercising my autonomy. So anyway, the doctors and nurses were very respectful of my autonomy, and they were trying to help me, giving me extra fluids and stuff to try to get me through radiation and past it, so then I could, start eating more. But I really lost a lot of weight. I was really in bad shape, and one day I couldn't hardly get up. And my partner and caregiver said, "We are going to the chemo center right now. I don't care what you say." So after we got there, he took one of the nurses aside, and he said, "You have got to make her have this feeding tube." And she took one look at me, and she agreed. And so she came over and got down in my face and said, "You really need to do this." so I said, okay. So I was so out of it, I just said, all right, I think what really convinced me to agree was the look on her face that made me realize it was serious, and I was really jeopardizing being able to finish my treatment, which was my goal, I wanted to get better. So I was hospitalized with failure to thrive, which is a diagnosis I always thought babies had. I never knew grown-ups had it. I realized I was facing a serious health threat and gave in. So I did have a loud TV and a roommate whose friends kept bringing in fast food, which was not what I wanted to be smelling at that time. But there were a few glitches. I went in on Friday before Memorial Day, and one thing we learned in our group is you never want to need medical treatment before a 3-day weekend. So, was I going to be able to get it by Saturday? So I could leave yesterday till Tuesday. But anyway, everything worked out. I didn't have any mistakes or infections, and it was really fine. And the feeding tube turned out, I didn't love it, but it was functional, and it allowed me to gain some weight, and it was really helpful. And if I had accepted that tube earlier, I would have avoided a lot of discomfort, and I wouldn't have lost so much weight, and which was hard. You may think it's easy to gain weight, but it's pretty hard when you're that much out of sync. So I really made a bad decision. I overestimated the burdens of this thing, and I underestimated the benefits. And I was a relatively well-informed layperson. You would think a medical ethicist ought to be able to make a decent treatment decision, but I didn't. So any thoughts about that? And feel free to say I was an idiot. I'm very open about this. I can't believe how stupid I was. I was. But, the doctors and nurses pretty much up until it got pretty bad were very cooperative, helping me be autonomous. Any thoughts about that? Yeah.
Jason.
Maybe we'll have somebody different who hasn't.
Were you pretty well informed, or did you understand sufficiently well that how long you would require the feeding tube in terms of during the course of your radiation, or was there an actual risk or a perceived risk that you would become, conscious still, Terry Schiavo or Nancy Krzan, permanently dependent on the feeding tube?
Well, I had been told ahead of time that happens to some people. There wasn't really, I don't think that was so much in my mind. It does bring up how when you're in the midst of something like this, you tend to focus on the immediate burden. So that's what I was focused on. I wasn't thinking too much about that. The way they do it is, though, they say you have to have it until you reach a certain weight. And so that made me, I was living on 5 bottles of Ensure a day, even though I hated that stuff, because I really wanted to get off it. But no, I wasn't so worried that I would be on it forever. I just didn't want it at all.
So how much does trust play, both in your own sense of self, but in your relationship with your physician, to both hear what they're telling you and then act on what they're telling you?
By the way, both of my oncologists have read this chapter, and my radiation oncologist said, in my experience, there are 3 types of people. When you tell them about the feeding tube, there's one category where they say, I want it right now, preemptive, just give it to me. Second, where they play it by ear and eventually want it. And the third, stubborn group. And he says, you were one of the most stubborn ones I've ever had. But I think one thing that didn't work right was, at least my memory is, and I tried to fact check some of this, but it is my memory. When you're going through treatment, the people who are giving you the chemo and the radiation, they're focused on doing that. So they don't look at the big picture and say, wow, you've lost more weight, you really need to think about this feeding tube. They never brought that up. And so when I would see the doctor, it wasn't that often, and it sort of really went downhill in between doctor visits. And so I think if somebody had said, well, at the beginning we said, well, 50% people need it. It's getting more and more to look like you need it. And if you don't take it, you might have to stop your cancer treatment. So, here are the benefits and burdens at this point in time versus before the decision was made. That would have been very helpful. One doctor I really liked, oncologist, did bring it up and say, there's always a feeding tube. And I said, well, I don't want to go in the hospital. And he said, well, it would involve a few days in the hospital. But he didn't really sort of argue with me, try to persuade me. So some of the chapter is about justified persuasion. You want to respect autonomy, but when you're patients who, I don't think I was incompetent. I think I understood the facts. I think I was just making an irrational choice. And you talk about values as being the basis of a treatment choice. Well, people have values, and then they have values like stubbornness. And those values were driving my choice. And sort of say, what is it that you're worried about? Why are you so, this is, the procedure itself is simple, this little tube, you tape it up, you can wear a normal shirt, not that big a deal. You want to talk to some people who've had one, that would have been helpful. I think I could have been persuaded. But they, one possibility was they knew that I worked there, and I worked with doctors who had said to them, don't be careful with her. And so maybe they were too deferential. I don't know. But it's so important, persuasion, and even I wrote a piece about how sometimes doctors should argue with patients. Now, knowing when to do that is very difficult, but I think it's very important to realize that when people are going through a serious illness like this and debilitating treatment, people are not themselves. And, Peter, my partner, he's going, you need this feeding tube. And, he was the one who finally got the nerves to cut me into it. And people need, once you become a patient, you still need to be argued with. Every decision is not the right decision, just like in ordinary life, right? You want people to talk with you about important decisions you're making if they think maybe you're not, the decision I was making was not really consistent with my true values, which was I wanted to survive and finish the treatment. So, yeah. Yeah. I'm sorry, I haven't been repeating the question. So this question was, the fact that I'm an attorney make me a better or worse patient?
The radiation a little higher.
Yeah, probably. They never told me about that. But, well, I've never been a real lawyer. So I don't think, I actually don't think I think it was more my individual character that affected my judgment. So I don't know. You'd have to ask other people about that. Yeah. A law professor. Exactly.
And he didn't think of suing him?
No, the funny thing was in this group of 7 people, there were 2 of us with law degrees. And John actually has sarcoidosis, which wasn't diagnosed properly. So one of the physicians in our group kept saying I was also, a couple of us were misdiagnosed or related to that. And so this doctor in the group kept saying, well, why didn't you sue? Why didn't you sue? And the lawyers kept saying, well, we didn't want to deal with that, you know. So I guess maybe if you know what's involved in bringing a lawsuit, you know that you don't want to take that on. I was seen by an otolaryngologist who who just dismissed my symptoms. And I was very angry about that later on. But I never even wrote him a letter. I kept saying, I should at least just write him a letter and tell him about me. And I just didn't have the energy, you know? I mean, I guess I had the energy to write this book. But I felt that would be constructive. And, you know, it really is so demanding to go through an illness like this that you don't do things that you might normally do. Oh, sure.
Right. I just wanted to. Hi, Rebecca. How are you? I wanted to observe that you've raised a really interesting dilemma for the patient and articulated in a way that I haven't heard it articulated before, which is that when you are ill with this kind of thing, you are really not yourself. And yet, 20 minutes earlier, you said, well, you're still yourself. So, you know, someplace in the middle there is something very ambiguous and difficult for both the patient to grasp, but then also for the practitioner to know, where is this patient? Are they feeling like they're themselves at this point, or are they feeling that they're completely alienated from self? So that's a really hard thing to gauge, I believe.
Yes, the point was about how when you become ill like this, you're not your real self, but you still are yourself, and you might change over time. And yes, one thing that it may sound as though we're very critical of doctors and nurses in the book, but overall, the message is it's much more complicated than we thought it was, and that you all have a harder task than we realize. And one of them is, first of all, many oncologists don't meet the patient, you know, until they already have a serious illness. So you don't know what kind of a person this is. And so you're filling them out. And my oncologist who read the chapter said, you know, I try to sense how much I could push the patient and what's appropriate, but it is you know, a gamble, a guessing game. And then another thing we write about in here is when people would say stuff to us like, oh, well, I'm sure you're going to get better. Sometimes we really wanted to hear that, but 20 minutes later, we wanted to punch them in the face when they said that, because how do you know? You know, I might not get better, so appreciate that. So there's really no way to win. But no, that's not true, but it is, you really, there's no recipe or formula to do all this right. I think being aware of the complexity and trying to sense where people are is probably the best you can do.
Well, I'm afraid that the hour has come to the close, but I hope Professor Dresser might have a few minutes to stick around if anybody would like to come up and ask her any questions. In the meantime, I'd like to thank you so much for